Hello and welcome. Today, we're going to dive into a pretty incredible AI-powered tool that's really changing the game for anesthesiologists, helping them manage one of the most common and dangerous events in the operating room, a sudden drop in blood pressure. So just imagine this for a second. Instead of reacting to a crisis after it's already started, what if the clinical team could see it coming minutes ahead of time and actually prevent it? This is the huge shift we're talking about today, moving from just reacting to what's happening to being truly proactive, using predictive medicine right there in the OR. All right, here's how we're going to break it all down. First, we'll get into why we're trying to prevent this in the first place. Then, we'll introduce the AI tool itself, which is called the Hypotension Prediction Index, or HPI. We'll look at how it actually works, how doctors use it to make decisions, check out the clinical evidence, and then, we'll get real about its limitations and what this all means for the future. So, first things first, let's talk about the problem. Why is a drop in blood pressure, or hypotension, such a big deal during surgery? Okay, so intraoperative hypotension, IOH for short, is super common. But common doesn't mean it's harmless, not at all. We have tons of research that clearly links these blood pressure drops to really serious complications after the surgery is over. We're talking heart attacks, acute kidney injury, and even postoperative delirium. The crucial point here is that for decades, our monitoring has been totally reactive. The alarm sounds, the team sees the pressure is low, and then they treat it. But by that point, the patient has already been exposed to that low pressure, and potential organ damage may have already started. And that's exactly where this new approach comes in. So let's meet the Hypotension Prediction Index, or HPI. At its heart, HPI is a machine learning algorithm. It's not just looking at the blood pressure number like we usually do. No, it's constantly, second by second, analyzing the shape and characteristics of the arterial pressure waveform itself. It's looking for these really subtle patterns that tell us a drop in pressure below that critical threshold of 65 is on its way. And the output? It's brilliantly simple. It's just a single number from 0 to 100. That's it. The higher that number climbs, the more likely it is that a hypotensive event is just minutes around the corner. Typically, an alert gets triggered when that value goes over 85. And this is not just some guess. The algorithm was built by feeding a massive dataset. We're talking over 130 million cardiac cycles from thousands and thousands of real surgical and ICU patients into a machine learning system. So it literally learned to recognize the complex physiological signatures that come right before a drop in pressure. But here's the really cool part. HPI isn't just a warning bell. It also gives you deeper clues into why the patient might be about to get hypotensive. So let's see how it does that. So, along with that main HPI score, the system gives you these key secondary parameters that help figure out the root cause. First, there's dP by dt. This basically measures the heart's contractility. You can think of it as how strong the heart's punch is. Second, we have E-radian, which is a really clever metric for pressure responsiveness. It helps predict whether giving a patient fluids is actually going to work to raise their blood pressure. This is huge for helping clinicians choose between giving more volume or a medication. And it's this combination of prediction and physiological insight that lets clinicians follow a structured, proactive treatment plan. This here is the clinical workflow in action. So that HPI alarm goes off, the clinician then follows this kind of logic tree. First step, check the preload. Does the patient seem like they need fluids? If yes, they then check E-aden to make sure fluids will actually help. If E-aden says nope, then a vasopressor is a better choice. But what if the patient isn't fluid responsive at all? Well, then the focus shifts to dP/dt to check the heart's contractility. See, it's a guided approach to find the right treatment before the crisis even hits. Okay, so the theory is fantastic, but does this predictive monitoring actually make a difference in the real world with real patients? Well, the evidence from multiple randomized controlled trials is pretty powerful. For example, in thoracic surgery, a 2023 study found the HPI-guided group had way less hypotension. In major gynecologic surgery, another study found the amount of time patients spent with low blood pressure was dramatically lower in the HPI group. And in something as complex as cardiac surgery, researchers found that 5 minutes before an event, HPI could predict it with 84% sensitivity and specificity. That's pretty impressive. So that brings up the next really big question. Traditionally, to get this kind of detailed waveform analysis, you need an invasive arterial line. But could you get the same prediction not invasively, with something as simple as a finger cuff? A head-to-head comparison study answered exactly that. And the data shows a really remarkable agreement between the HPI values you get from an invasive line and the ones from the non-invasive clear-sight finger cuff. The bias between them is low, the correlation is strong, and, maybe most importantly, when it comes to triggering that critical alert when HPI hits 85, they agree over 86% of the time. And this is really the bottom line right here. The actual predictive power, what we measure with something called the area under the curve, is nearly identical for both methods 5 minutes before an event. What this does is open the door for this technology to be used for a much broader group of patients, not just the ones who already need an invasive line for other reasons. Now, like with any new tech, HPI isn't a silver bullet. It's really crucial to understand its limitations, too. First off, the algorithm is a black box. We don't know the exact secret sauce inside. Its high sensitivity means you can get false positive alerts, which could lead to overtreatment if you're not careful. Its accuracy can also get thrown off by arrhythmias like atrial fibrillation. And of course, like any analysis, it's garbage in, garbage out. It absolutely depends on a clean, high-quality signal. And finally, its use in kids is still an area that needs more research. This quote from a recent review really sums it up perfectly. The cardiovascular system is incredibly complex, and an AI can't see everything a human clinician can, right? It doesn't know when a surgeon is leaning on a major blood vessel or when the operating table is being tilted. These are the kinds of real-world challenges that still need to be worked out. So all of this leaves us with a final thought to chew on. The ability to predict and prevent hypotension is without a doubt a massive step forward for patient safety. But is this the end goal? Or is this just the very first step in a much longer journey of integrating artificial intelligence and predictive analytics into the super complex, high-stakes world of the operating room? It's a fascinating question for the future of medicine. Thanks for tuning in.